cardiovascular pathology, atrial fibrillation, and others. All right, so to begin off this section, we need to talk about narrow complex tachycardias, okay? And this is what AFib is known as and all the others that I'm going to be talking about today. And the reason that they call it this is just because, once again, you have a narrow QRS complex, okay? And what that means is that it's less than 120 milliseconds, okay? To me, that means nothing, okay? And I know that it should mean something, but if you're like me, I just get rattled with all of these like random boxes and stuff like that and how long one thing should be and how short one thing should be. I don't care. Okay, so I'm going to give you so many other things that you should be looking out for that's going to help you. If you're really good at finding out that there's a narrow complex tachycardia, good job. Use that. That's going to be for your advantage. But to me, okay, if I have trouble with like this, I'm going to kind of give you everything that you need to know about AFib and other things like that you don't have to look for the narrow QRS complex. But okay, I digress. The narrow QRS complex should be less than 120 milliseconds. That's like around 3 small boxes, okay? So use that if you want to use that. But let's start off with atrial fibrillation. Now, the one key word for atrial fibrillation is irregular, okay? And so what they love to say is that the beat is irregularly irregular. Your heart is irregularly irregular, okay? That means that the rate and rhythm are both irregular. Okay, I've said it a million times. I've said irregular probably like 5 times in the last 2 seconds just now, but that is the most important thing. If you see and they will say it, it's shocking, but they will say it. They will put it in your vignette, okay? They will say irregularly irregular, okay? If you see that, you're dealing with atrial fibrillation because it's the only thing that's irregularly irregular, okay, that we really care about that's high yield, okay? There are other things that are, but for our purposes here, atrial fibrillation is what we care about that's irregularly irregular. So what does that mean? I've said it a million times. What does that mean? Okay, that means that you have an irregular rate and an irregular rhythm. So rate, okay, what is rate to me? Rate to me is just your heart rate, okay? So for example, if someone's heart rate is 60, okay, that means that they have 60 beats, right, per minute is how we calculate it now. Okay, so 60 beats per minute, that's your rate, okay? Now, in an irregular rate, okay, since it's a tachycardia, it's going to be quick, okay? So you're going to have a very quick heart rate, okay? And not only that, you have an irregular rhythm. So irregular rhythm would just be boom, 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 right? The distance between each heartbeat is the same. It's regular. But the problem with atrial fibrillation patients is that they have irregular rhythm. So the difference between each heartbeat is going to be different. Okay, and that's the key way that I look at it. If I see an EKG and I look at one R interval to another R interval, if one RR interval is completely different than another RR interval, okay, and I keep on looking there's no reliability to any of the RR intervals, then I know that I'm dealing with atrial fibrillation, okay? So make sure you understand that. That's the first key concept, is that the RR intervals are not equal to each other at all, okay? With an irregularly irregular rate and rhythm. Boom. First one. Second thing I look for, no P waves. You have no discrete P wave. And now, can we think about the reason as to why that would occur for someone that has atrial fibrillation? Well, in atrial fibrillation, you have no atrial kick, okay? And without an atrial kick, right, what do we know about the P wave? The P wave is the atria, right? Is it depolarizing? Okay, so the atrial depolarization is the P wave. Well, if we don't have that atrial kick, we're not going to have that full atrial depolarization. Hence, boom, it's gone. There's no P wave, absent P waves. Okay, so that's the second thing I look for. So one, irregular rate and rhythm. Okay, and we see that with the RR intervals not being the same. Number 2, I look for no discrete P waves. Okay, number 3, not written in your book, but something that I always look for, is that sometimes or another, now it's not all the time, but sometimes the vignette will give you some hints. It might say, hey, this patient comes in and they feel like there's like a hiccup in their heart rate. It's fluttering. It's making weird, it feels like it's doing weird things, okay? So they might say that, they might throw it in. Start thinking about atrial fibrillation as one of those causes, okay? Now, next, what are the common risk factors, okay? Now, the most common risk factor that you have to know, they love to ask about it, is age, okay? Anytime you have increased age, okay, that puts you at a greater risk for atrial fibrillation. It's the number 1 risk factor for AFib, okay? Now, number 2 and other things that can cause risk factors is left atrial dilation, okay, or excessive alcohol usage, okay? Excessive alcohol usage. Sometimes the patients will come in, they say, hey, I drank so much last night, doc, now my heart feels like it's like fluttering, it's feeling weird, it's beating out of beat. then you ask the patient, oh, well, did you drink a lot last night? And then they might say yes, okay? So excessive alcohol use can predispose you to AFib. But that one thing that I said is left atrial dilation. Whenever you have a change in the structure of your heart, that predisposes you to disease, okay? So it's change in the structure of that left atrium is going to predispose you to atrial fibrillation. So left atrial dilation can predispose you to atrial fibrillation. But remember that number one thing is going to be increase in age, okay? Now, let's talk about why atrial fibrillation is scary, okay? So to start us off, what's going on here is occurring at the left atrium. Something that I never really understood until later on is that when we're talking about atrial fibrillation, we're talking about the left atrium. We're not talking about the right atrium. We're talking about the left atrium. And that left atrium, once again, isn't able to do the atrial kick. So we're not fully forcing all the blood out of the left atrium and into the left ventricle, okay, because we have this fibrillation. So what happens is that a lot of that blood stays in the left atrium and it's just sitting there and it's sitting there and it's sitting there. And as we know, as blood sits, okay, it has a tendency to clot. And with this tendency comes the formation of, as we know it, a blood clot, okay? And that blood clot likes to form in that left atrial appendage, okay? It's just sitting in that left atrial appendage, that blood clot. And then now, since it's a clot, it has the ability to be shot up into the left ventricle. And then from the left ventricle, it could go up and out and cause a stroke, okay? So a stroke is one of the biggest risk factors that we need to be aware of to make sure that this does not occur, okay? So how can we fix this? The treatment is very important, okay? You want to get rate control down. You want to get rhythm control down, okay? So because it's irregular rate and rhythm. So you want to control your rate of the heart. You want to control the rhythm of the heartbeat. And you want to give the patients anticoagulants, okay? So that's the triple therapy that you need to know for AFib. And we're going to go into what are those later on, okay, in the chapter at the end of the cardiovascular unit. But make sure you keep that in mind. Rate control, rhythm control, and then finally our anticoagulants so we don't get that stroke because of that blood clot formation, okay? Now, if we can't do anything, we can have definitive treatment, meaning that we can just completely end atrial fibrillation. And how do we do it? We ablate the location in which this is occurring, okay? So we essentially just break off this electrical current, okay? And the current usually comes from the pulmonary vein ostia. And that's something that they like to ask about, okay? So what they're going to do is they're going to put a probe through your heart. They're going to access it through the right side because how are they going to access it on the left side? It's very hard to get through the left side of the heart, right? So you have to access it. You have to access it through one of the veins in your arms. And then from there, they're going to access the right atrium. And then how are they going to get to the left atrium, right? From the right atrium to the left atrium, because that's where it's occurring. They need to ablate the pulmonary vein ostia. The pulmonary vein, right, it drains into the left atria. How are we going to get there? Well, you're not going to go through all of the lungs and stuff like that. You just have to go straight through that atrial septum, okay? So right through the intra-atrial septum, and that's how it accesses the left atria in order to ablate the pulmonary vein ostia, okay? Very important. This is a very high yield topic, atrial fibrillation. If you have any questions about it, please let me know, but I'm just going to do a quick overview just so you know it. All right. Irregular. So important, rate and rhythm. There's no P waves present, okay? Next, you have an increased risk with age, okay, larger age, also with any type of structural abnormality like left atrial dilation, okay, and alcohol usage. The clot forms, okay, if it's just sitting there, there's a clot that can form in that left atrial appendage and lead to stroke, which is a very scary thing that we need to make sure we don't allow happen, right? It's an outcome that we don't want. And the way that we can treat it is with rate control medication, rhythm control medication, and anticoagulants. And if that doesn't occur, we're going to have to ablate the pulmonary vein ostia located in the left atrium. All right? That's all for right now. It's a narrow QRS complex, less than 120 milliseconds, and it's a tachycardia, right, as we know it. I'm going to cover the other ones in another video, lower yield stuff, but just make sure you know this AFib.